So my name is John Marshall, and we're shooting live today from the 9th annual Fighting a Smarter War Against Cancer Ruesch Symposium focused on GI cancers. And I'm joined by two of our amazing speakers today, Dr. Tim Greten, Dr. Julia Druce, who are here to really focus on a new topic, a sort of not so new depending on where you are with things, but certainly now making it to the forefront on how to think about cancer differently than we have been. Tim, let me start with you. I know you've done a lot of work on sort of host factors and the like. Just tell us a little bit about what you're going to talk about in the meeting and how that's going to impact sort of cancer therapies moving forward.
Sure, John. So basically, my group is really interested in the local environment of the tumor that arises in the liver. And a while back ago, we started addressing this question by looking at how diet and obesity and fatty liver disease can affect, for instance, anti-tumor immunity. And we have seen that in mouse models that obesity is actually impairing anti-tumor immunity. And now we have seen that this even has an effect if you use a therapeutic immune-based approach, that this treatment doesn't work as well in mouse models if there is in the context of obesity. So that was one approach which may lead to interesting questions if we treat actually patients that are obese. And then more recent.
Let me dig on that. So have we actually looked at immune responsiveness versus BMI, for example?
Well, that's an interesting question, and that's an ongoing research. There are actually very recent publications that have started to look at this. And as always, the questions are depending on where the obesity arises and where the tumors are, that you may actually see different effects. Overall, we do know that obesity may actually be a risk factor, and at least is associated with a number of diseases. Outcome is a little bit more difficult because, as you know, patients that have a very low body weight to start with usually have sometimes a worse prognosis. So I think the field is still very, very open. But it's an interesting research area. And now, more recently, we started asking, like many other investigators, the question of the gut microbiome, which I believe is very fascinating. You hear these numbers. There's like so many bugs everywhere. When I talk about this, it starts itching, right away. And it's not only that there's many bugs, but they have even way more genes. And how this is all being regulated is I think, really, really fascinating. And so, I'm going to talk about our findings where we looked at this and basically find that if we use very crude models to eliminate bacteria in the gut, we see fewer tumors in the liver. And, to be honest, I first couldn't believe it, but it just, we repeated and we looked different models, and there seems to be a very nice association between no bacteria and elimination of the bacteria using antibiotics. And fewer tumor growth. And then we got really, really interested in this and finally found out how this whole thing works. And just to give you just a brief overview, basically we noticed that bacteria in the gut can actually control bile acid metabolism in the gut. And these bile acids then go through the portal vein back into the liver and control anti-tumor immunity.
Is it, we're old guys, you're not so old. And so, why has it taken us so long to sort of look at this side of our health, of our human beingness? I mean, I think, we've evolved over millions of years, if you're one of those who believes in evolution, that in fact, why did we keep bacteria inside of us? And yet we've not really focused on that. Any thoughts as to why we've ignored it for so long?
Well, I mean, I don't think we just had the techniques to really study them. These studies are so complex, and you need genetic studies, you need any multiplex studies, technologies. You need to know the bioinformatics. It just wasn't feasible to do this a couple of years ago, and also keeping mice under germ-free conditions. That's all very, very difficult, and I think that was just the main reason.
Yeah, Dr. Druce, I want to hear from you as well. I know you're really lab-based and at Johns Hopkins, and just a great program there, and I know it seems to me that almost everything we look at, we find something new quickly. I mean, this is a very high yield science
Yes.
because it's so new to us.
Yes.
So tell us a little bit about what you're going to share today.
Yeah, so I'll be talking pretty broadly about the role of microbiome in GI cancers, and I'll mostly focus on colorectal cancer because that's very near and dear to the Sears lab. But I will go over some of the findings where we know that the microbiome has so many different roles. And I think that's what's so interesting about it. You know, we know that the microbiome can be bad, right? But we also know that it can be really good. It's really protective in homeostasis, and it's really important for normal gut function. You know, they help degrade dietary fibers and do all these wonderful things. And perturbing that is what we think might contribute to disease. And then, you know, after you have cancer, there's this whole new field now too, where we're thinking about the role of the microbiome in treatment of the cancer. There's been a number of wonderful studies looking at immunotherapy, you know, mostly in melanoma and lung cancer, but hopefully we'll see some more GI cancers soon if immunotherapy gets approved for those indications.
Yeah.
And then finally, you know, we always get asked, you know, well, should I be taking probiotics?
This is what I want to know.
That's what everybody wants to know. And you know, the data.
Has anybody done a study where you eat your you test your microbiome, if you notice my angles here, you eat a probiotic and you show that it changes your microbiome?
So,
can you feed your coral reef from here?
You know, I think all of the studies where they've started to look at probiotics, and even in mouse models where you're trying to feed these probiotics, it's actually really hard to get true colonization. You know, as soon as you...
I always joke with my patients that you don't need to put it in this way. Maybe you need to put it in that way.
I mean, FMT works great, actually. That's the interesting thing. Well, it's... So fecal microbiota transplantation is this, it's actually an old concept, but it's been gaining in popularity again because of recurrent C. difficile infected patients. And in those patients, they have a really dysbiotic microbiota to start with. So usually they probably took a course of antibiotics and that's how they got C. diff to begin with. So their microbiota is already very dysbiotic. And if they, you know, clear their gut microbiota with a bowel prep or antibiotics again, and then get this fecal microbiota transplant from healthy patients, it actually cures them of their C. diff. Now, people are trying to use FMT in other disease indications like IBD, and what's really interesting about that is that in patients who maybe have a little bit of dysbiosis, it's much harder to get these other bugs to stay. They have to do repeated transplants, like 3 or 4 or 5.
It's hard to restore a coral reef.
Yeah.
Like once you disrupt it, is that sort of is that a decent analogy?
No, it's actually the opposite. If you have a destroyed coral reef where, you know, it's a terrible landscape, it's actually pretty easy to fix it with FMT. Again, in recurrent C. difficile. And again, I think we don't have enough data on all the other disease indications that people are looking at FMT for, but I think one of the, you know, not so cancer related, but one of the most interesting things that I was reading about where OpenBiome, one of these commercial stool banks, is partnering with groups is in trying to restore antibiotic susceptibility in other, say, like vancomycin resistant bugs, where maybe giving FMT to those patients actually will also get rid of the bugs, similar to C. diff.
Yeah.
I think there's some really interesting applications there, but it's still too early, I think. But going back to the probiotics, it seems like they can't hurt you from what people have shown so far. You know,
but they're not
asterisk.
controlled either. I mean, there's a whole wall of them
No,
on the pharmacy, and you don't know what you're taking.
Yeah, I mean, you can eat yogurt.
Yeah,
you know, and
eat some dirt.
that's a probiotic.
This
yeah,
is what
absolutely.
I recommend highly. Just eat dirt.
Yes.
Let me ask one last question because we could go on all day. I know on this topic. You know, I've got this hunch, and some of the literature supports it, that this emergence of young people with colon cancer is a microbiome effect. What's your thought on that, Tim?
Well, I don't know. I mean, I don't think we really have any data. I mean, I very much agree on the dirt. We do know that plays a big role for different diseases, autoimmune diseases, and you know, and not. And I don't know yet if we live too clean, and
Right.
that's basically where you're going with this, and that may cause earlier colon cancer.
Julia, what do you think?
I think we just don't know. I think it's
Gotta figure it out.
we have to figure. And and I know my mentor Cindy is definitely actively involved in talking to folks, trying to recruit these patients and figure out why they are seeing cancer in these patients who are in their 20s and 30s. And who don't have an APC mutation, germline.
No,
So
they're half
I
our
don't-
clinics nowadays. We gotta figure it out.
yeah.
I'm really excited to hear you guys talk. Thank you guys so much for joining us, and I know our audience will be very appreciative of what you shared just now. Thanks a lot.
Okay,
problem.
thanks, John.
Thanks.